right? Non-specific STT wave changes, all sorts of weirdness. Sometimes they present with this. So what's this? Interns. I have a lot of easy questions. I don't always pick on the interns, but I feel like these are low-hanging fruit. What is this? Inferior stemming. Thank you. This is an aortic dissection. How many minutes do you have to get someone to the cath lab to when they present to the ER with a stemming? So you have 90 minutes. How long do they stay in the ER? Like 4.5 seconds, right? Who here knows how John Ritter died? Yeah, chest pain, taken to a fancy hospital, gets an EKG that shows a stemming, is taken immediately to the cath lab, where he's found to have an aortic dissection and he dies. Your job as an ER doctor, I mean, you look at this EKG, you hear the patient has chest pain, clearly you're going to get this whole stemming thing going. Your job as an ER doctor is to make sure that patient does not have anything else before they go to cath lab. Cath lab does not help anything except for stemming, all right? The ACEP guidelines say very clearly that a chest x-ray should be done on all patients with a stemming before they go out. God forbid they have a pneumothorax or something weird, or you look at it and their mediastinum takes up 3/4 of their chest. That's an aortic dissection. So these are some of the stats. 10 to 15% of people with aortic dissections have ACS or are diagnosed with ACS. 4% are STEMI. If you give these people TPA, they don't do well. Okay? So this is that chest x-ray with a aligned aortic nub. Yeah. 10% of people have a normal x-ray with aortic dissection. You're not doing a good enough test to rule it in, rule it out. And that's the ultrasound we talked about. If you don't see it, you got nothing. And then tests. All the tests that look at this, they more or less say two things. Aortic dissection is associated with an elevated troponin and an elevated creatinine. I think it's because you're ischemizing your renal arteries. That these are not things that are going to really help you or put you in the right direction, but it might be worth thinking about. If someone comes in with chest pain and they have an acute kidney injury, go back. Think about aortic dissection a little closer. And next we have D-dimer. This could be an evidence-based medicine lecture all on its own. Who here has used the D-dimer to rule out aortic dissection? Yeah. So there is literature supporting it, and there is literature not supporting it. And I think that this is in the gray area of medicine. One troublesome thing is on ACEP's last clinical guidelines, which there have been papers published since then, but in their guidelines, they think D-dimer is not ready for prime time. And if you can all imagine the Fagan nomogram, a D-dimer only works if you start out low risk. And we have not clearly defined exactly by a clinical decision rule how low that low risk is before it's over. I will say if you have a negative D-dimer, it seems to imply that you will have a lower post-test probability, but whether or not you can effectively use that to rule out disease is a, I think, doctor-to-doctor decision, right? And who here has had attendings that do different things than other attendings? Right? I think D-dimer is a little bit like that. Question. Did you have your hand up? Oh, you were saying that you've had attendings like that?
Yeah, I was putting my hand up really hard.
I've been there. I've been confused. So if you're going to diagnose an aortic dissection, what are you going to do? Second years. Click on you guys. Yell it out. Call CT surgery. I mean, once you diagnose it, maybe CTA. CTA, perfect. So I really enjoyed the amount of papers that are like comparing these and looking at likelihood ratios, right? These are all quote unquote equal in diagnosing an aortic dissection. I guess if you're really sick, you tube them and you do a TE in the ER. I don't know if I've ever been anywhere that can do that. And I'm not really sure when an MRI would ever be better than a CTA. I'm trying to come up with scenarios. What?
Pregnant woman.
Pregnant woman? I don't know, man. How long does an MRA take? Up to you guys, but know that these three are equal, and I would always get a CTA. All right. So if you want to rule it out, the only tests that can do that are these three. EKG, chest x-ray labs, none of that should influence your medical decision making in a rule out kind of way. All right, I know we just did one, but I want another moment. Molly EQH Reed last night, he took his hypertension meds today, and now he's off balance. And then some people might remember this patient because I could yell about him for months, but this is his chief complaint. He got Narcan and woke up and then asked what day it was and what time it was and then whether it was AM or PM and then said, Doc, I gotta go. And signed out AMA. But he was very entertaining. All right. So let's say you do your fancy test and it shows you have dissection. Our next question is, what are you going to do, right? This is board, bread and butter. We'll fly through this. Is this ascending, descending, or both? Descending. What's your treatment? Yeah, medicines. Bring down the blood pressure, bring down the heart rate, and you're going to call the surgeons. You're going to put in a surgery consult. All right? Ascending, descending, both. Both. Ascending, descending, both. What's the treatment? Surgery first. This is go to OR now, but ideally before they go, you'll hang something. Because they need medication control as well. Don't forget that. Now what medicines, this is another challenging evidence-based medicine topic because guess what? There's no randomized control trials. Pretty much all recommendations start with the beta blocker. Okay? Esmolol and labetalol are the two that most commonly are the recommendations. And it's drip. On the test, as far as I know, the next best answer is nitroprusside, but that one's dumb, and people don't seem to be using it very much because it has lots of side effects and we're not used to using it. Reading a lot of these articles, I actually really like nitroglycerin. Who here's used nitroglycerin before? Who here's comfortable with it? It's quick on, it's quick off. It actually is a perfect drug for this. So I do beta blockers followed by nitroglycerin. There is this idea that you can use nicardipine too or calcium channel blockers. It's a little bit tricky. Long story short, pathophysiologically, it seems like that would make sense instead of a beta blocker. We don't have a long record of them being used. But at the same time, it's not like we have randomized controlled trials that show a beta blocker is good. So beta blocker, nitroglycerin, hopefully you don't need a third line agent. Now what's your heart rate goal? What's your number? Third years, fourth years. Some figures in that 60, right? They say 60, maybe a little less, and then the blood pressure goal is a little all over the place. Some guidelines say 120, some I read said 100. One editorial said as low as the patient can tolerate, which that one seems a little fishy to me. But the idea is like, who here's had a hangnail, right? I know moisturize. I get hangnails all the time. Who here's got a hangnail stuck on Velcro? Yeah, so that should make you squirm a little bit. Now you're in an aortic dissection. You're literally just taking Velcro and you're rubbing it on a hangnail every time your heart beats. So ideally, you would get it to rub less often and bring down the heart rate. And you would make it rub less hard and bring down the blood pressure. And that will hopefully be less painful and cause less problems. So that's your goal, okay? So that's basic learning world. To treat all aortic dissections, labetalol, nitro, goals, heart rate less than 60, I put a blood pressure less than 120, but there's a little variability there. And call surgery, depending on ascending, descending, ascending emergently, descending urgently, I guess. All right, last moment of silliness. This was not at Kings County, but reminded me so much of Kings County in this lecture. Look at the chart. I've had some regrets in my short life, and one of them was that this lady left alone before I could see her. I had so many questions. Like, where is she going to go back to her apartment now and just pretend like nothing happened? But unfortunately, a nurse came up to me and said she walked in to introduce herself, and the patient was like wrist deep, and there was change on the bed, as well as like crumpled dollar bills. And then the patient looked up and said, "I'm getting out of here," and like scooped up the money and ran. I love it. How great is this? All right. So not to play with your guys' emotion, but we're going to go from a moment of silliness to another real case. Obviously, this sad. Who knows who this is? Author of Frank. The writer of Frank, right? Jonathan Larson. This was a young guy. To make the case a little tricky, there's some people who think he may have had undiagnosed Marfan's. But he wrote Rent. He was a very young guy, and it seemed like it was going to be the next big hit. During rehearsal, he had syncope, chest pain, shortness of breath, dizzy vomiting, and all this is published online, but there are all sorts of issues, like he had an episode of near syncope and got really diaphoretic while in the ED. That's documented by a nurse, but it's unclear if that was ever seen by the doctor. And the other tricky thing is he came in and said, you know, I've been thrown up a few times, and then I had chest pain and I fainted. I think I had a bad turkey sandwich. So, pretty easy to hear that in a young, healthy guy and say, you're fine. He came back with chest pain, epigastric, abdominal. This time they did some tests, an EKG, trope, a chest x-ray, some basic blood work. Diagnosed with Aortic syndrome yet again. And discharged, and then concerningly on this is he was tachycardic, right? So they've done a lot of studies on bounce backs, people who poorly undiagnosed tachycardia on discharge, or tachycardia without cause on discharge is a high-risk future. And then he went home and was found dead, not so accurate. Taken to the hospital, didn't make it out. They did an autopsy, and he had an aortic dissection with a pericardial effusion and potential tamponade. And I bring this up because this, you know, we go over the evidence for these historical factors, and I get that in this case, the history and physical were not complete, but I think this is an eminently missable case. And that brings me back to kind of this, right? So you're going to see a crap load of people with chest pain in your career. And believe it or not, there's an 80-to-1 ratio of those diagnosed with ACS versus those diagnosed with dissection. So it's no wonder that I see great documentation in history and physicals for ACS with chest pain, less so for aortic dissection. If you see enough people, which you will in your 30, 40, with the way medicine's going, 100-year career, and there is a chance that these people are going to have a dissection, statistically speaking, you are going to miss one. And there are some attendings that hear this, or doctors that hear this, and they think, well, gosh, I'm going to scan everyone. And obviously the test has risks, and you don't want to scan everyone. But you get to choose who you diagnose. Another thing I learned in Kings County that I think was a very valuable lesson is the idea of, during discharge, asking yourself for every patient, if this guy is found dead at home in 2 days, if this girl comes back and is sick, what are the most likely things that she's going to have? Do I want to think twice about testing for those here, or at least documenting X, Y, and Z, or at least talking to the patient and giving better return precautions? I think this stopgap is crucial in how busy we are in thinking critically and fully about every case, right? So a couple of facts already went up, talked about, but you will discharge someone who bounces back. When you Google bounce back, you get a lot of like funny looking kids and like heroic postures. But we're actually talking about bounce back like Mike Weinstock, like patient bounces back sick. Next, right, along these statistics, people die, right? You can see someone with a stupid case of chest pain that clearly has nothing, and if he dies 2 days later, what's going to happen? That chart's going to get looked at. And if you did not do a complete history and physical, or document a complete history and physical, that might be something problematic for you. Now, I know that this is a dice roll, right? How many patients are you going to do a complete job documenting on to save yourself this one piece of trouble? How many patients are you going to do that stopgap on to rethink or do an extra test or have another talk with someone? It's a tricky question. I think you need to decide for yourself what your risk aversion is, but it's something that I think needs to really be considered strongly. And I kind of want to just scare the pants off you guys a little more in terms of doing a complete history, physical, and documentation. These are some real cases. Isolated left leg pain. An episode of global transient amnesia. Guy was driving, all of a sudden he didn't know where he was going, who was in the car with him. It was like one of his good friends, and it went away. It's a classic case of what that was believed to be pericarditis with tamponade. Acute urinary retention, right? That's it. Most sensitive sign for cord compression. Here, cord compression was secondary to dissection. And then there's this one guy that's like convinced that you get aortic dissections from spikes in blood pressure, as well as chronic hypertension. And they did a study where they had all this thing is like such an ortho thing to do, but they had the people in the study lift weights and they checked their blood pressure. And when lifting, their blood pressures got systolics over 300. So if you're going to get aortic dissection, think about exertion, Think about these elevated blood pressures. Next, this one actually I find really interesting. This was a young lady who's a medical student who got in an argument with her significant other, developed chest pain, shortness of breath, and finger tingling. What does she have? Anxiety. She gets out of it. She calms down. They go back in to reassess her, which thank God they did. And what does she say? I feel calm now. My chest still feels off, and now my hands are really actually numb. It's not like a tingling, like I can't feel them at all. Right? And this fits the exertional component, right? She's in a fight, her sympathetic system is going, she's upset, blood pressure goes up, aortic dissection. This one made me laugh for many reasons, partly because I'm grossly immature, but postpartum leg pain, the guy got an MRI and then followed up with his doctor as an outpatient. And the doctor's like, hey, you know that leg pain you have, you don't have pulses anymore. And he had an aortic dissection. These guys, people that come in and are just a mess. Multi-organ system failure, altered mental status, could be from a dissection. Intestinal ischemia, cord compression, we kind of talked about a little bit, and then this looks bad, right? Like my lady. She looked back, I knew she had something, or at least I felt like she had something, and all the tests I had done, I ruled out 6 of the 7, she had aortic dissection. So I think that brings us to kind of our little philosophical rambling, and my apologies. But I think in medicine, with all these clinical decision rules and all this evidence-based medicine, this is what we're trying to do. We're trying to eliminate uncertainty and subjectivity in medicine. In aortic dissection, we still have a lot of subjectivity. We still have a lot of uncertainty. And it's funny because I feel like when I was reading this article, all this stuff was being published, right? There's a whole New England article about teaching med students about uncertainty. And it also makes me laugh because sometimes you talk to residents and you say, well, what about aortic dissection? And no way, this guy's aortic dissection, right? There is uncertainty in medicine, and this is part of it. And then what would be a philosophical lecture at all without a picture from sweet mustached William Osler, who, how old is this guy, like 300 years old? Medicine is a science of uncertainty and an art of comfort. And I get that you practiced before we had medical tests and whatnot, but I think it's something to think about when you see your patients and you're in the grind is, how certain are you about diagnosis X, or that someone doesn't have diagnosis X? And leave that little bit of room for doubt to make sure you do a complete job. And then it brings me, nothing's more complete than a Dumb and Dumber quote. Does anyone know this part of the movie? Am I the only one that hasn't memorized?
I got it.
Who's gonna play the girl? What's the line?
1 in a million.
Yeah. What are the odds of a guy like me, a girl like you? Just give it to me straight, Mary. She says, not good, Lloyd. He says, not good, like 1 in 100. She says, like 1 in a million. And he says, tell me there's a chance, right? There's always a chance. So this is what it comes down to, right? It comes down to Yoda on your back, right? Jimmy Willis's whisperings in your ear, right? You have to decide for yourself whether or not you think someone has an aortic dissection, whether or not you think someone needs a CTA. And think about all the things I talked about when you get there. All right.
I feel like that's not I mean, it's difficult. And actually, Reza actually did a presentation on this critical care lecture last year that prompted me to do similarly in checking pulses, asking about neurodeficits or paresthesias and so on. But the thing is, I mean, as you said, a lot of it is subjective. And in asking a lot of people about these things, it was, oh yeah, this happened, and I felt, a little numbness and tingling in the fingers, and then you get all sorts of other things that, I mean, in theory should raise your pretest probability. But I find it difficult, and there's a number of studies that were negative, thank God, CTA is never done. But at what point what does it for you in terms of maybe raising that pretest probability, especially with the subjective things that people will say, like what is it that?
No, it's really hard. And there's a lot of somatization in the Caribbean population, and the language barrier always makes things difficult. In LA, I work a lot with underserved Hispanic populations, and they always seem to describe their pain as piquetes. Piquetes. Who here is Spanish speaking? How would you define piquetes? Stabbing pain. Interesting. I've heard it described. What? Yeah, I've heard it described a few different ways. And the Hispanic population they seem like they somaticize frequently as well. But I think it's all up to you, man. It's all your risk aversion and how much you want to. I mean, so if you bring up a funny point, so the other thing to think about, and there's one study on this, and they did all this fancy statistics, and they decided that the right number for testing threshold, and this, by the way, made it into ACEP guidelines, which I think is kind of funny, is 167. So they say it is worth scanning 167 people for an aortic dissection to pick up one. I'm like, that like blew my mind whenever that was like, what, I've probably scanned 30, 40 people, and I picked up, what, 4 or 5, maybe 6, right? And it's your testing threshold and how risk averse you are. And that's one reason why I also like that stopgap, is you're like, you know, because my assessment plan, your assessment is like one sentence. 47-year-old man presents with chest pain. If you're going to write and left-handed numbness, right? If that guy comes back to the session, it's going to look troublesome. But I think it really just depends on you and your testing threshold. I don't think there's a right answer. Any other questions? All right. So this is my last learning point. You get to choose who you miss. You get to choose who you scan and who you clinically feel does not have a dissection. But you need to do your due diligence. So, my summary. Consider your rule we missed, predisposing coram pulse neuro, chest pain plus 1 rule. You do not have a CDR. This is all on you guys. To rule it out, you have to do a CTA, an MRI, or a TE. No other tests are effective. And you get to choose who you miss. Any other questions? Dr. Willis.
Other than you mentioned the difference in blood pressure, was there anything about being hypertensive or hypertension?
No. You assume that, and I've heard that, but it didn't come up in any of the literature I read. Unfortunately.
My other question is, why do you have emojis on your curl?
Say that again?
Why do you have emojis on your curl?
Oh, because, you know, you're so scared you're pants. It's an attention getter. And, you know, these days, you gotta be hip to get the millennial learners to come to you. And they love emojis. They're all about emojis. All right. Questions or pieces? My cute kids. I like them a lot. I recommend, if you guys want babies, I highly recommend it. For like 6 months on. Before that,